The very first slide said, do we have any disclosures, and there was none. I do have one. I was born and raised in Detroit, about 30 minutes from these guys' facility, and I'm a Michigan State fan, so I'd like to disclose it makes me sick to my stomach to see University of Michigan on every single one of our slides. What you're seeing here is actually a, let me see if I've got, if we go back. This is a simulation, and the simulation itself, yeah, I don't know, it won't start up. There we are. What you're going to see is there's actually tools out there now that will actually run a design and start to test a design before you complete it. This was a design where we could reduce time to physician from 96 minutes all the way down to 31 minutes, as well as other reductions in pediatrics. So I just want to let you know that there's multiple tools out there to help you through the actual design process. Small actions equal big changes. The one thing I would like to say is when we as a design team tend to show up on site, you know who greets us at the door and wants to jump right into the design? The ED nurses. And the ED nurse is there because they want to talk about flow, they want to talk about problems, they want to talk about all of the different potential solutions. What we find with ED physicians, because you're so busy, is that you tend to say, when you have a drawing of the design, let me know, I'll show up at that meeting. And as all the slides that Ben just showed you, there's so many decisions that need to go in before you even start to draw when you talk about strategy and operations and flow. So all of those items are going to build to huge changes. The other thing I'd like to say is that don't assume that an architect that's done some ED design in the middle of Kansas, some community hospital, understands academic medical centers. I can tell you right now that the actual working and charting areas need to be 30% larger in an academic emergency department because of the numbers of bodies you have, the teaching functions, all of that. You can see flexibility is a huge part of what we need to do. It's understanding that future demand. It's talking about optimizing flow. Remember staffing. I can't tell you how many times I've seen other architects work with a facility staff, and the first time that the doctors and nurses try to figure out staffing and coverage is a month before the ED is done being constructed, and they walk in and say, how are we going to cover this? Who's going to cover what rooms? Think about staffing during the design process. There's a lot of modular solutions. By limiting monuments, we mean try not to build in casework, try not to build in items that can be portable, that can be movable. Who knows what you're going to be doing 10 or 20 years from now? Think about 15 years ago and what fast track was. Now think about what you're, quote, doing in these non-urgent areas are so much higher complexity. So try not to build in more movable items. This is just a simple configuration of showing a nurse station on the left. When people tend to expand, they just build another nurse station on the right. All the rooms in the middle are clean and soiled and toilets, you can't see through them. Now suddenly you're designing you're running two emergency departments. When you really want to move the support to the perimeter, you want to be able to tie your department together so you can flex up and flex down. Flexibility and staffing and coverage and visual safety is extremely important. And even as you get to larger emergency departments, central control areas that can start to see all parts of the emergency department. You want to be able to accordion up and accordion down. If there are any rooms in the middle of the emergency department, they should be glassed in. This is a medication room that people can see through. There are also teaching spaces that are glassed in. Do not glass in every single nurse station. I will tell you that when you glass in a room because you think it's going to make everything more quiet, it's noisier because the noise has nowhere to go. But if there are spaces for teaching and residents where there's going to be a lot of conversations and you don't want to necessarily have the patients overhear them, you need to consider glassing different items in. Be careful about mirroring rooms back and forth. We're taught this in architectural school because it saves a little bit of money by putting sinks together, back to back, $500 in plumbing. When really what we want to be able to do is develop every single room exactly the same. So that when you come in, you know where the supplies are, you know where the computer is, everybody knows where they're supposed to be within the room. There's also the concept of flex space. You don't necessarily need to double the size of a room, you only need to add in about 30 more 30% more space, and you can overflow to a second stretcher. And most states are going to allow you to do that. Yes, nobody wants semi-private rooms, but what we really don't want is hallway care. So when we start to talk about the future, there's a single room on the left and there's the flex room on the right. So I'm going to hand it off to Jamal, that's going to talk about a lot more about the workings at U of M. The one thing I will tell you is get involved early, get involved with all of those early decisions.